Thank you so much for having me, and it's really a pleasure. I don't know how many of you guys out there are dealing with patients with pigmentation, but here in Texas, we see it all the time. And so I was just going to share some of the pearls of what we've experienced using combination therapy. And I think as we go into the future, a lot more people are going to see how to utilize combination therapy with their own practice and their patients. What we do know is that melanogenesis is prevalent, and it's an immune response. So for those of you guys who are scientific like me, I'm a super geek with this. I love to see what the technology is or what the pathophysiology is so we can see if the technology can address it properly. And so when you look at your slide deck here and you see that the melanocyte is at that basal layer, the very bottom layer there, and about every other 7 to 8 cells is going to be the true melanocyte. And those are going to get upregulated by heat, the trauma, sun, and anything else that can go on causing some inflammation. So what are some of those common causes? Well, we know about actinic damage, and you can see here, severe actinic damage from the sun, both on the chest, the face, forehead. You can see it on the arms. Of course, here we see the pigmentation spots on the left nose there. We see it over the entire back of the hands, and it's on these sun-exposed areas. That's very, very common for that to occur. Let me see if I can get the next slide here. So what happens as we mature? And these are telltale signs, and we see this on a regular basis here. Let me see if we can go one slide forward. Thanks. Okay, and if you see right here on this gentleman, when you can resurface the skin or you can do something to address the pigment, even though there's a lot of similarities, you're going to notice that the skin looks more fresh and the patient looks more refreshed. What are some other causes? We have post-inflammatory causes, and so that's going to be anything from acne to melasma to any kind of inflammatory process. So that can be a eczema. It could be anything that's going to cause that inflammation. So when you look here, what happens? We get this post-inflammatory hyperpigmentation. Again, anything that's going to cause the skin to be irritated, whether it's an external force or an internal force, is going to cause an increased production of melanosomes. So the melanocytes are going to produce more melanosomes there. And so you can see in these common pictures that we see. Probably the most difficult condition that I treat in the office is melasma. And I dread melasma patients because it's so difficult to actually treat these patients. And it's, no matter how much we do in Texas, there's so many causes that we don't even know yet. We do know that there's going to be some relation to heat. So it's not just sun exposure, but it's heat, and also there can be some abnormalities in endocrine function. It can happen to anybody. My wife is a type 2, type 3 skin, and she has melasma. So it's a frustrating condition. It's not always for those who have skin of color. When we go forward one slide here, let's see, there we go. I always wonder, as I add something to my practice, I want to make sure there's 4 things. And for those of you guys who've heard me talk before, I always talk about the same 4 things. It's boring. Number 1 is, what are we going to add? Is it going to be something that's safe? If we know that it's safe, then I want to ask myself, is this new product or whatever it is that we're adding, is it going to be efficacious? So if it's safe and it's efficacious, then I ask myself, is it something that I can do in the office easily? So that means that if I need to train somebody new on how to do this, or I need to show the patient on how to utilize something, is it easy for them or for me to do? And then if all of that makes sense, then I ask myself, is there a true return on investment for whatever this is that we're going to add to the office? And so you always start that discussion off by seeing what is it that patients are looking for. And for those of you guys who have body contouring devices in your practice, what you'll notice is that there's double-digit growth going on for the past 3 to 4 years, and it's expected to grow by 16%. But the one constant that has never changed is patients looking for improvement of skin texture and discoloration. We see that all the time. And so what are some of these traditional treatments that we have? Well, we know there's topical agents, and so that's your sunscreens, your hydroquinone products, your non-hydroquinone products, so your azelaic acids and your retinoids. For chemical peels, there's so many chemical peels out there, and I'm often asked by estheticians that come to the office, how do I choose a chemical peel? And I'm going to break it down to something that's very simple and something that's going to be safe that we use from PCA Skin on a regular basis. And I used to have these TCA peels. I used to do my own modified Jesners. And what I find now is I don't need to do that because we have customizable peels from safe companies. Historically, we've used laser treatments. We've used, of course, our fractionated and ablative and non-ablative lasers. Of course, we use our Q-switch lasers. What's missing here is the picosecond lasers that we also utilize for pigment. And of course, in the past, we used IPL. And IPL has gotten more and more powerful for certain types of conditions, but you do have to remember that it's going to worsen melasma. What are some of the limitations that we have? So with topicals, if you have most non-compliant patients like myself, they're not going to put it on. Does it actually work if it's not put on? It's not working by osmosis, that's for darn sure. What's the side effects? So we know with retinoids and azelaic acids and even hydroquinone, these can all irritate the skin and cause worsening of that pigmentation. So there are some limitations. How about with chemical peels? Well, we used to have to figure out what's the timer before we neutralize that chemical peel. How much downtime is it? And really, unless you're really an expert in peels and have studied this in dermatology, you're not going to quite as easily understand how to customize these peels to a patient's skin type. And what are the limitations? And one of those is the skin types there. How about for lasers? We know that lasers in the right hands are incredibly safe and useful, but in the wrong hands, we treat 3 to 5 new laser complications a week. So that's a big number that we're seeing there. And again, can we use lasers on every skin type? If you understand how a laser works, yes, but otherwise you're at big risk of limiting your patient population or damaging that patient. So when we look at what's the ideal laser, I always look at, again, what's the power, what's the depth of penetration, can we use it on all skin types, can I use it on a variety of conditions, and what's the consumable that's there. I think all of those are very, very important, and how robust is that device, meaning does it break down? So those are all things that I'm looking for. And with the diverse population that we have in Houston, where we're seeing skin types 1 through 6 in our practice, one of the safest lasers that we have is the Nd:YAG. It's a 1064 nanometer wavelength. And if you're ever going to look at studying lasers, you have to understand this wavelength absorption chart. Because lasers are going to be targeting a chromophore. So that's basically what's the target that's going to absorb this light. And the 3 major chromophores, and now there's a 4th one, which is fat, but the 3 major chromophores are hemoglobin. So if you have red blood vessels and things like that, you have pigment. So that's how we do hair removal. That's how we're removing some of the pigment that we're going to talk about here. And of course, water. So water is what we target for rejuvenation. So the nice part about the Nd:YAG is it can address all of these, and it can help address pigment by focusing on both the dermal and epidermal component as well as the vascular component. When you look beyond the wavelength, you have to figure out what pulse duration, that means how long is the pulse firing, to keep it safe for your skin type that you're treating. The best part about the 650 microsecond technology, which is the Aerolase, it's amazing. And what it does, it's so short, the pulse duration, that it confines the heat. And if you look at this little hair graph in front of you, you can see the shorter the pulse is, the more localization there is going to be just to the hair follicle itself, rather than generating heat as you go to a longer pulse. So that's what a big difference is, and that's what makes this particular device so incredibly safe, and really we reach for it more and more every single day the longer I have it. So in terms of the 650 microsecond Aerolase, what are we using it for? We're using it for a variety of things. Number one, like we were talking about with this talk, is pigment. So we want to be able to target pigment both at the epidermal level as well as bypassing into the dermis to get rid of more pigment that's there. And usually melasma, if you use a Woods lamp, you're going to be able to determine where the majority of that pigment is. If it's superficial, you can use the Aerolase to break up some of that pigment, but you can also use a chemical peel, and you can address it, customize it for that patient. With all melasma patients and with all pigment patients, there is some vascular component that's there. And we know that it's there because if you get rid of some of the pigment, you're going to start seeing more red that's underneath. And of course, you know, who doesn't want to improve their skin tone and texture when you're getting a treatment anyway? So here's some of the conditions that this particular 650 microsecond Aerolase treats. And we're going to talk about all of these, so there's no reason to read that out loud. And again, let's move on to chemical peels, because now we're going to combine them in a second. What's an ideal chemical peel? It's something that we can treat every single skin type. You want to make sure that there's HQ alternatives, that's hydroquinone alternatives, because there are many people, and the most recent literature shows about 31% of patients that we know of have some type of sensitivity to the hydroquinone. So it actually makes that pigmentation worse. So I've really moved quite far away from the HQs whenever possible. And then again, how do we customize it for that patient there? And that's where the PCA is going to come into play here. And again, I'm just sharing things that I use in my practice. So as you guys gather your questions and you start writing in, please, share what your practice is like and see if it seems to make sense at all. So when we're talking about melasma and hyperpigmentation, there's certain ingredients that we know are going to work every single time. We already talked about hydroquinone. TCA is trichloroacetic acid or concentrated vinegar. Retinoids or retinols, and retinol is the precursor to tretinoin is really what it is. L-ascorbic acid, we already know, is vitamin C, and that's stabilized by vitamin E. So you see all these vitamin C and E products. The vitamin E really doesn't do anything other than stabilize the vitamin C, which is the L-ascorbic acid. Azelaic acid, we know about, kojic acid, of course, and alpha hydroxy acids. And they're not that powerful, these alpha hydroxys, but they do work synergistically. When you're looking at a chemical peel, you have to ask yourself, where is it that I want to concentrate? Where's the pigment, or where's the damage, or what is it that we're trying to do? And in our practice, we mainly concentrate on superficial and medium chemical peels. The deep peels we used to do under anesthesia, those are the phenol peels. If you are utilizing them, just be a little bit cautious, and I'm sure if you're utilizing them, you're experts, but you do want to do some cardiac monitoring for phenol peels. But for everything that we're using in the office, we do not need to have a cardiology background, and these are quite safe. When you're talking about these very light or light superficial peels, what is it that we're trying to do? We're trying to improve the skin texture, of course, but more importantly, we're trying to remove the superficial layer of skin. So that's through the mid to lower epidermal layers there. And when you're using some of these peels, we do have to be a little bit more cautious on skin types 4 through 6. And the nice part is, and this type of peel, we used to also be very cautious for certain types of patients, of course, darker skin types, but also those very, very fair skin types that have a lot of sensitivity. They have allergies, they have redness. There's a lot of things that are going on with those patients. And so we find a way that we can treat all of them. Of course, your medium chemical peels are going to be more effective because it's going to penetrate a bit deeper, but you're going to have more significant peeling, and this takes anywhere from 8 to 10 days to go away rather than the superficial peels, which you can limit to almost no peeling but still have microscopic improvement versus 3 days or 4 days of peeling. And then again, we talked about these deep chemical peels, and really that should be treated like a ablative laser that's there. When I look at adding peels to my practice, and if for those of you guys who do know me personally, I travel a lot to teach, and it's one of my passions is to be able to be out of the office and share our experience. But so those 1 or 2 days I'm out of the office, I want to make sure that everybody in our office, all the patients, are being treated safely and appropriately with our 3 aestheticians and our nurse practitioner. And so what do I want to do? I want to make sure that there's going to be something that's effective that they can apply safely. And 2 of these peels are the PCA peel with hydroquinone. So we talked about whether to use hydroquinone or not. And there's one with hydroquinone. There's one that's a modified Jesner's. There's a hydroquinone-free, as well as one that has resorcinol. Now, resorcinol, for those of you guys who are adept at using these peels, you know that's going to cause a little bit of heat. So if you're treating the post-inflammatory hyperpigmentation, you can use the hydroquinone and resorcinol or the hydroquinone, but if you're treating melasma, you want to be a little bit more cautious, and you might go for something that's hydroquinone-free there. The Sensi peel has been an amazing addition to our practice because we can treat every single skin type. It doesn't matter how fair or how dark, utilizing this peel. And the ingredients there are the TCA 6%, and you say, well, that's only 6%. I have 15% that comes from McKesson. Well, yes, but the 6%, when you put it in combination with the lactic acid, which is going to calm the skin, and then you have the kojic acid, azelaic acid, and arbutin, it's going to be more effective than just 6%. It's going to give you, with 1 or 2 layers, anywhere from the effectiveness of a 10 to 15% TCA peel. And you can really modify it for any skin type, including those that are most sensitive. We often use a 6% pure retinol peel, and these are for the patients that tend to have a lot of actinic damage. So they either have actinic keratoses, or they've had a lot of precancers or even early skin cancers, and even superficial basal cells. The nice part about this page and the page I showed you before is that you're able to combine these to customize the peel and treat the melasma and the post-inflammatory hyperpigmentation, as well as acne and other conditions that we're talking about here. The nice part about combining both chemical peels as well as the Aerolase and at-home topicals is they're synergistic. And so I'm just going to share with you some of the things that we found in our practice to work quite well together. And here's why it works, and I call it the 1-2 punch. The laser treatment is going to help us get down to the dermal level. So it's going to help with the hyperpigmentation that's sitting at the DE junction, the dermal epidermal junction. It's also going to help with that hypervasculature that we talked about. So that's the redness that comes along with melasma and even in post-inflammatory hyperpigmentation. And the side effect of all of this is you're going to have some collagen remodeling, which is going to tighten the skin. With the chemical peel, we know that typically we're going to go down into the mid-epidermis, sometimes even the lower epidermis there. And the nice part about this is that the 650 microsecond peel is safe enough to allow you to do the chemical peel on the same visit. So if you don't mind, I'm going to have Sean go ahead and play this video for us, and you're going to see how we combine this on a regular basis. And this particular video was shot about a month ago, and we just did another treatment of this today. Can you go ahead and play that video for us, please?
Yep, loading up right now.
You can see the Aerolase is being treated. It's contactless, so there's no, because it's so quick, the 650 microsecond, it heats very, very gently, and you're not worried about the cooling. You don't need a cooling tip, you don't need cryogen, you don't need anything on there. And so very, very safe here. This is a patient with melasma, and I'm going to be showing you her results in the next slide or so. So immediately following there, we go ahead and clean off the face. We applied acetone to degrease, and now we're applying a PCA chemical peel. And in her melasma has been so resistant and so annoying that we use the hydroquinone free, so you don't have any resorcinol or anything like that in there to cause any heat, hexoresorcinol. Can you go back to the slide deck if you don't mind? Wonderful. We'll go to the next step. Let me go to the next page here. So, some of the clinical pearls, and you're going to see this in just a second. We definitely do preventative maintenance. So every single patient, before we start them on any pigmentation treatment that's in the office, I want to make sure they have a great at-home skincare regimen. So that means of putting them on the appropriate retinol. I've replaced actually every other company's retinols in our practice with the PCA. They have 4 different types of retinol, so I can customize it to every type of skin, including that rosacea sensitive skin. And I hear it on a daily basis, oh, I've tried Retin-A and it doesn't work for me, it's too irritating. You know what, I've got one for you. So it's been remarkable. We have something called IBT, that's intensive brightening treatment by PCA, that's also retinol. And these all have the effectiveness of a 0.1% tretinoin. Clinically, that's how they are as effective. But the difference is it has something called omnisome technology. And I know that when we talk about these things, lasers are sexy, but the vehicle of a skincare product is not that sexy. This one is, and the reason for it is because this omnisome technology allows the retinol molecule to penetrate deeper into the just past the DE junction, so it doesn't sit on top of the epidermis like most of the retinols and Retin-As do. So that's the advantage of this. It also stabilizes the retinol, so you can add other ingredients, and that's why there's 4 different types of retinols that you can get from this particular company. So it's pretty neat there. So every single patient goes home with a retinol and a sunscreen. I ask them to utilize that for at least 2 weeks before they come in for their treatment. If somebody is incredibly impatient and they have an event that's coming up, then what I will do is I'll go ahead and utilize the I'll utilize the Aerolase, apply some vitamin C and E to that area to help get rid of some of the pigment. I can put either a azelaic acid or lactic acid light peel on at the same time, and then I also start them on that skincare regimen at home. So let me go to the next slide here. So this was the patient that we were treating in that video just a few seconds ago, and you can see that if you compare the right forehead just above the brow to the right forehead post-treatment. Just it's a single treatment with one PCA peel, and this is incorrect. It's without hydroquinone. So I apologize for my error. But you can see that there's a nice changing and a brightening. It is the same exact flash, and the skin on the right side of your screen looks so much brighter. And again, it's because the pigment is not absorbing that light, and that's why you see this nice change here with both the freckling as well as the melasma. Here's another patient that we treated single neo treatment, and then we used the Ultra Peel Series 1, and you can see the dramatic change that goes on. One thing I do caution for those of you guys who are not dermatologists, make sure that if it's not improving or that pigment seems to be really resistant and you say, I don't know, that's so weird, go ahead and, if you're a dermatologist, obviously take a biopsy and see what it is, or recommend a dermatologist for the patient to see, make sure that you're not missing something like a melanoma. Here's another case of a patient that we treated using the Aerolase and the PCA, and if you look at the right side of the screen, look at the incredible brightness of her skin, and she was so pleased that then that forehead line that you can now see because the skin is so bright, she went ahead and asked us to treat. Here's a patient of Cheryl Burgess. She's out of Washington, D.C., amazing researcher, an amazing dermatologist, and you can see using the Aerolase treatment with the glycolic in combination, the dramatic effect that you can see with just one treatment. Here she's treating same thing, Dr. Burgess here, she's treating the scar with melasma, and you can see the brightening of the skin, and you can see decreased visibility of that scar. And again, the Neo is just a great addition. It's the Aerolase Neo is what it's called. And look at this horrible resistant melasma that this patient has. And again, Cheryl's done a great job using a combination of the Neo and a PCA hydroquinone-free product here. Again, it can affect any skin type. This happens to be a skin type 4 patient, and this is a single Neo peel with the single Neo treatment with the hydroquinone peel here. So just to give you an idea that we use it on a regular basis. Again, another patient of Cheryl's treating melasma, which is significant. And here we have Michelle Henry. So the reason that I have a variety of slides that some of our colleagues have shared with us is because it's important to say, hey, you know what, it's not just in your practice, it's not just my practice that it works, but it's across the board. And it's really important to see the changes that we can affect. So in this patient, it's not melasma, but it's post-inflammatory hyperpigmentation. This has been really a neat device, and it's been a real popular device for our aestheticians. We're happy to treat acne now because we can get quick treatments and quick results. So this is only after 2 treatments. Look at the incredible change on her skin. One of the more difficult things, and I don't see it as often in our practice, but most of our dermatologists complain about this, and now they send it over to our practice, is a pseudofolliculitis Barbie. Patients hate this, so you can treat their pseudofolliculitis where it's an actually ingrown hair. The only, of course, you want to warn the side effect to the patient is that you are going to lose hair in that area. So that's what's going to treat it. But look at the improvement, and it's really something that's a game changer for men. So anytime we do a procedure in the office, I make sure that that patient is on the proper skincare regimen at home. And why? It's because it's going to allow that patient to have a more rapid result as well as having ongoing results. So they don't have to come to see you as often for that same chemical peel, but they're going to ask about other things that you offer. And so how do we enhance this? My favorite easy step is to use the post-procedure kit by PCA. I was very reluctant at the beginning to actually spend money on this. I think our retail cost is maybe $25 or $30, maybe $40 at the most, and we bundle it into those patients that need this to have an enhancement of their chemical peel. And so anytime we're doing a stronger peel or we're doing the laser combined with peel, we go ahead and bundle this into their take-home package, and they love the ease of putting it all together. How else do we enhance the outcomes? This is what I was talking about earlier. This is another at-home product, this intensive pigment eraser. Remember, this does have a HQ 2%. The niacinamide that's inside there actually helps heal the skin, and the hexyl resorcinol will help as an agent there. The post-procedure kit, our cost on it is $19, and I think we bundle it in around $40. I'm just getting clarification on that. But you can see treating with the intensive pigment eraser, it's a nice change when you're using the Aerolase combined with this. You're going to get more significant results. My favorite vitamin C and E now has become the PCA. I've actually replaced 2 other products. We had a lot of the SkinCeuticals vitamin C and E ferulic, and what I found is that even though it's a very popular product, it didn't have as much science as I'm seeing with the PCA products here. And so this is really a neat product. It does not cause dryness, and this is something that you want to have patients put on in the morning, not in the evening, because this is an antioxidant. If you're putting it on in the evening and it has no effect, and the antioxidants are what we're trying to prevent. We're trying to prevent the oxidation that's occurring to increase the melanosome production by the melanocyte. And again, this is after using Aerolase and the PCA chemical peel. What we want to do, especially through the summertime and the wintertime, is to have that particular patient applying the vitamin C and E to give you better long-term results there. What else can we do with these products? Well, that's my favorite thing. We are pulling it out on a regular basis. Of course, we showed you active acne. And again, this is not my patient. This is Kevin's patient. He's a dermatologist, a friend of mine in Chicago, and you can see really after 4 treatments, it's a pretty dramatic effect. And these treatments are done anywhere from 1 to 2 weeks apart for our patients. And these are oftentimes, there's patients that are either failed Accutane, they couldn't tolerate the side effects, or they're reluctant to start on Accutane. This is a patient of mine that I treated, and she had severe folliculitis combined with acne on the back and the face, and she's never had anything work, and you know, not on any hormones or anything like that. Young lady has had babies 15, 16 years ago, and you can see just after a single treatment, this is 1 week later, she's so pleased with it, she came and asking what else we can do for her. This is a medical spa in New York that shared this slide using the Neo for laser hair removal. Again, look at the skin type. This is skin type 5, and we can safely remove it because it's an ND-YAG laser with a very short pulse duration. What else can we do? We can treat the rosacea and the redness with this, and this is a family practitioner that's in Pennsylvania. And then here again is Kevin Pinsky, and he's also utilizing this for skin rejuvenation while he's removing some of the pigment. So that's a nice, you know, it's a very useful device. For those patients, if you are treating a lot of spider veins, it is another indication. Is this a patient that I would treat with the Aerolase? I would actually refer to one of my colleagues who's more patient with it because it takes a little bit longer, and I'm just not a fan of treating spider veins in our office. But I do treat veins on the face all day long with this device, and it works quite well. So again, it's just a quick summary. You know, what's the overall benefit? The 650 microsecond is unique. There's nobody else that has it. And I still remember when I first saw the Neo, our laser colleagues were making fun of me for saying, hey, you got a YAG in a bag. I said, well, that's creative. Until you actually look at the science behind it. And when you talk to the head researchers and the technologists at Aerolase, it is remarkable because they've taken this old technology where we have these huge boxes for our ND-YAGs, our Ruby lasers, and our V-beam, our Ruby, pulsed eye lasers, and they've combined it into a 1064 with a very short pulse, but it can generate really high energy without hurting anybody. There's no service contracts with this. It just works. It's amazing. So again, why are we using the laser? We want to go to the dermal level or the DE junction to break up the pigment. In this case, you guys who use lasers on a regular basis, you understand that creating heat will actually cause the melasma to worsen. So this is firing so fast, it's like your picosecond laser where it's just shattering using a photomechanical version rather than a photothermal damage to break up the pigment there. Then we use the chemical peel. So we're going to target the epidermis in this layer here. And then, of course, the at-home products we've already talked about. One of the things that I emphasize, and I didn't want to forget, is for those of you guys who are just starting in the aesthetic industry, make sure you track the changes. A lot of people have asked me, is it worth the cost to invest in a photography system? 100% it is. So really find something that's going to be able to highlight the pigment as well as taking good photography. This is my personal information, so if you do have questions afterwards, please reach out. I know that Aerolase, Sean, and I, we're going to be working together to answer any questions that we can't answer right now. So with that, Sean, I'll turn it back over to you, and I'll be happy to take any questions.
Yeah, so thank you very much for that presentation. And again, we will open it up for questions. So if you have any, please type them in. So I'm going to start off with one question that was asked here about the chemical peel, specifically glycolic peels. What percentage do you typically use, and does that run patient to patient, or how do you address that?
It is. We use it, combine it, it's very customized based on the patient. Nowadays, I'm using more of the glycolic peel in combination with something else. So we'll have a TCA 6% along with the glycolic, and usually the glycolic goes anywhere from a 25% to 75%, and it's more synergistic. But again, like all of these things, it's going to be a little bit more customized.
Okay, and then going into the customized treatments, I mean, how do you determine whether you use a chemical peel, a combination of things, or the laser itself?
That's a great question. So I'm going to be basing it on the Woods lamp, and you can order a very inexpensive Woods lamp off of Amazon. Just look for, it's called a black light, and then you can see where the pigment is. And if you're noticing a lot of pigmentation when you turn that on, and that's usually superficial pigmentation. If you're not really seeing this kind of glowing look, then it's usually deeper pigmentation that's inside there.
Okay. And we have a question about whether you still have an IPL and use it, and do you ever use a tyrosinase inhibitor to pre-treat?
So I do. So the tyrosinase inhibitor, you're talking about tranexamic acid, I presume. There's both an oral component as well as a topical. The topical, a variety of companies have the topical inside their ingredients. In terms of the oral, it's not FDA approved for the U.S. yet, but our colleagues overseas have recommended that you use 250 milligrams twice a day. In the U.S., it's approved for 650 milligram, so you can ask your patients to take it, you divide it in half and take it, take 1/4 really, 1/4 in the morning, 1/4 in the evening. But have the patient check with their gynecologist, because there is a slight risk of, it's the same risk as your oral contraceptives for getting any kind of coagulopathy. So you want to be a little bit cautious about that. So I do pre-treat. Tell me again, Sean, there was another part of the question. You were asking about IPL. If we're talking about melasma, it generates so much more heat, I will not use it to treat melasma. We do have a Frax 1540 XD handpiece on there. It's a 10 millisecond pulse, but again, I never turn to it I actually turn to my Aerolase on a constant basis for melasma. If you're talking about skin freckling, if you're doing a larger area, our IPL, it hurts more and it takes longer to do. But if we're talking about a full face, I'll treat with the IPL first, come back and clean up anything that we need with the Aerolase there.
We had a question about comparing the Aerolase 650 microseconds to picosecond lasers.
So a picosecond it's anywhere from, it's about 95 times, anywhere from 25 times to 95 times faster. A picosecond is even faster than this. We have a Pico. We've got PicoSure by Cynosure, and it's interesting. I don't turn it on that often. It takes longer to heat up. It's the consumable. If I'm using the Focus handpiece on there, is more expensive. Where do we use it? We use it for those patients who have larger areas, and we still use it a little bit for tattoo removal, but I don't use my Pico as much as I used to.
All right, excellent. We have a great question here. So they're asking, so if there is pigment in the epidermal layer, will the laser reach the dermis?
It still does, yes. So some of that laser is going to be absorbed superficially. Some of the laser is going to be absorbed just below the dermal. It'll actually go through, because the pigment is not going to be uniform there. It does. And what you're going to notice, if you say you have more of a dermal component, you can use just a single pass or 2 passes of the Aerolase just to kind of break up that superficial pigment, and then focus more on the epidermal portion using your peels. If you and then once that gets cleared up, you're going to see that there's usually some portion that's a little bit deeper that's going to be needing more treatments or more passes with the 650 microsecond technology.
Okay. We have a question here about diffuse lentigines on the face and the hands, and how would you approach those?
So if you do not have an IPL, then I would use the 650. I think this is a neat device to be able to do everything like that. Otherwise, if it's a single lentigine, lentigo, single lentigo, then I actually pull out the Aerolase more frequently because there's no warm-up time whatsoever. It's instantaneous. It's amazing. And it wheels from room to room. My IPL that I have is a little bit more bulky, so to get it to warm up, it takes anywhere from 3 to 5 minutes, and I could have treated that patient and been on the road. If we're specifically treating the entire face and the backs of the hands, I typically turn to my IPL first, and then I'm going to clean up anything that's left over using the Aerolase.
Okay, great. And so, since we're talking about combining with chemical peels, we have a question about what's the time interval between applying the chemical peel after the laser?
It's
and which
immediate.
do you do first? Right.
I do the laser first, and then I apply the chemical peel. I want to make sure there's nothing in that chemical peel that's going to attract and really there shouldn't be, because it's mostly water content in the chemical peel. But I actually do the laser first, then I go to the next step. You can do it immediately afterwards. There's no cooling period. There's nothing. It's not like your IPL.
And then, so we do the laser first, then we have the chemical peels, and then we have a question about the typical home regimen for melasma. What do you recommend for that?
So every single patient that has melasma is on 2 things, and one is a fantastic sunscreen. I do recommend a physical sunblock, if at all possible. If it's somebody who wants a vitamin C and E as well, I'll have them use the vitamins. This is my exact regimen. I have them put the IBT on, so that's Intensive Brightening Retinol by PCA. It's safe for everybody. Every single skin type can tolerate it. And you just do a slow start. So typically that first week I'm having the patient treat maybe once or twice a week with the retinol, the intensive brightening retinol, and then I'll have them utilize a great sunscreen in the morning. So my favorite sunscreen from PCA is the Sheer Tint. It's a physical sunblock, and then before they put that sheer tint on, I have them apply vitamin C and E, the C and E Max by PCA as well. So the C and E is going to be the antioxidants that's there. The sunscreen obviously is going to block any sun exposure there. But then again, we're addressing some of the heat component with that vitamin C and E, and then the retinol with the combination of ingredients that are inside the IBT, the intensive brightening treatment, that's going to help fade a lot of the pigment, including the melasma.
Okay. So one of the questions we always kind of get is treatment pricing, and we all know that differs from region to region. But I wonder if you can give a little insight as to how you price everything when you're talking about combining treatments.
Happy to. I price treatments based on what type of revenue you want from that room per hour. So if you want to make, let's say, $500 an hour in that room, and your overhead is 50%, so whatever's taking an hour for you to do, or a portion of that hour, you should charge either a fraction of $500, or you should charge the full $500 if it's going to take an hour. The beauty of this particular combination, the Aerolase is very, very quick. It takes less than 10 minutes to do. The peel obviously is very, very quick, and it takes less than 5 or 6 minutes to do.
Okay, we have a couple questions about pigmentation and scars. Do you have a protocol for that, and how do you address?
So scars are going to be more difficult because it's very, very individualized. You have to see what caused that pigment. Is it actually more red, or is it actually more brown? Is it a keloid scar? Is it a hypertrophic scar? So first I identify what type of scar it is. Is it an atrophic scar, meaning that it's more of a depressed scar? And then usually with scars, it's a multimodality type thing. We're going to use the Aerolase at different settings, and we're going to actually turn up the juice there to kind of improve the collagen production there. If it's a pigmented scar, you can't do that. You want to break up the pigment that's inside that scar first. And then afterwards, right after using the Aerolase and the chemical peel, I'll actually, if it's a pigmented scar, I'm going to actually use a low-dose steroid. So part of that low-dose steroid is inside that post-procedure kit by PCA, and if you want to order something a little bit stronger, I just recommend triamcinolone, 0.1% cream. You can prescribe it for a patient. You tell them if it's their cash pay at Walmart or Target, it should be anywhere from $5 to $6 for I think it's a 30-gram tube to an 80-gram tube. Scars are very, very, they're unique. You really have to take it on a case-by-case basis.
Okay. All right, excellent. So now we have a couple questions about, so if you have a patient that's allergic to hydroquinone, how will you overcome that, what other products will you use? I know PCA has a lot of great, non-hydroquinone products for hyperpigmentation.
That's the beauty of the retinols that PCA has and that IBT, the intensive brightening. There's no retinol in it. And there's also a non-HQ pigment eraser as well. And that's for more spot treatments. But the retinol works quite well for the entire face. So I have every single patient on that, including my wife. You want to make sure that if you are using other products that you can use azelaic acid, you can use, what else is going to be there? You can do a hexaresorcinol, but really you need to put some type of retinol that's in there that's going to overturn the skin. You want to improve that skin turnover from 28 to 36 days to as short as 6 to 7 days turnover.
Okay, excellent. Let's see. Go through a couple more questions here. Here we have a question about what you're actually looking for through the Woods lamp that you had mentioned earlier to determine the different levels of pigment.
You have to. You can. I'm sure there's some YouTube videos on that. You have to train yourself on how to utilize a Woods lamp. You have to differentiate between epidermal pigment and dermal pigment. So where is that pigment? If it's more superficial, you're going to use more of your chemical peels, and you can use the Aerolase just to break up some of that superficial pigment. But if it's deeper, you want to address the deeper component first, or you want to get to the deeper pigment that you can address with the Aerolase.
Okay.
So the Woods lamp is going to help you differentiate between deeper pigment versus superficial pigment.
Okay. We have a question here about treating darker skin types or treating tan skin. Does your protocol change for those different skin types?
The protocol will change in terms of the Aerolase settings are going to be pretty similar. If we're treating melasma on any skin type, whether it's fair or darker, you don't want to create any heat. So again, because it's a 650 microsecond, it hits it so fast, it's localized to that area. If we're treating lentigines and something more superficial, we can go ahead and heat that skin, so you can do multiple passes with that 650 microsecond. In terms of our chemical peels, again, we want to make sure that we're not generating too much heat if you're treating melasma. So yeah, it does change slightly. It's going to help us. With every single person, I'm more conservative the first treatment so we can see how much they peel, because again, with the melasma, you don't want to have too much inflammation going on. So I'll typically use Sensi peel, which is again safe for every skin type. I'll put anywhere from 3 to 5 layers that first time, and I'll put if the patient doesn't have any hydroquinone sensitivity, I'll use a HQ peel on top of it. If they have a hydroquinone sensitivity, I'll use the retinol boost peel on top.
All right, excellent. So we have a question here, not necessarily focused on hyperpigmentation, but just laser in general. Prophylactics for antivirals, do you usually prescribe those?
If I always ask the patient if they've had a history of if they have fever blisters at all. And if they do, we don't need to really do it for Aerolase because you're not getting that much heat. But anything else that's traumatic, if you're doing a deeper peel, a medium peel to a hotter laser, then yes, I do antivirals. If you're doing anything ablative, I go ahead and start antivirals. And what I've realized is with some of our non-ablative technology that we're using with our Frax 1540 or 1550, whichever company you're choosing to use, I do go ahead and prophylact. If you're doing, in our case, if we're using radiofrequency microneedling, I also prophylact.
Okay. We have a couple questions here about other treatments as well. So, we're on the topic of combining treatments. How would you address 2 other treatments, acne and rosacea, with laser and topicals?
So in terms of acne, again, you want to have some type of retinol. If it's somebody who has a lot of acne, we use a product called Clarity, and it's a Clarity retinol. Again, it's by PCA. It's made specifically for that. They also have an acne spot gel treatment and a spot cream that has a combination of salicylic acid to calm down that inflammation that's there, some lactic acid as well. So I'll use that topically. I want to make sure that they're on a non-comedogenic, very lightweight sunscreen. And then in terms of the Aerolase, I'll treat them once a week depending on how severe their acne is. If the more severe it is, the more frequently I'll treat them. And the treatment sessions last about 10 minutes, maybe 12 minutes at the most. I think we charge $300 or $250. I don't remember exactly how much we charge for that per treatment. And patients are so happy, so they come, and as they start clearing, we start spacing them out a little bit further, 2 weeks, 4 weeks, until we get them clear. Michael Gold, who's done a lot of research in laser technology, he has an amazing patient that he's tracked for the last 20-something years, where she grew from a young teenager. At 11, she needed to go on Accutane. She's had 6 courses of Accutane, came back as an adult after her first child, and said, I'm so frustrated, I don't know what to do with this horrible acne. So he said, well, we've got this new device. He had just gotten the Aerolases a couple years ago, and he tried it. With 5 treatments, that young lady has now been clear for 2 years. So it's amazing what can be done. It's absolutely amazing. In terms of rosacea, we just completed a trial, and it happens to be a PCA product. It's called Dual Action Redness Relief. And again, we have several patients that they've been red their entire lives since they have keratosis pilaris, so they have some baseline redness since they were teenagers. And it's the first time they found relief just by using a topical. So typically, again, I want to save the patient some money, so we'll use the dual action redness relief. The price point is somewhere in the low hundreds, maybe it's $100 or so, and we have them apply that twice a day. It does 2 things. It actually constricts the blood vessels without having any kind of you don't have a rebound effect with it, and it also has niacinamide, which helps heal the skin, so you're not going to be as easily triggered because you're going to have decreased transepidermal water loss with your rosacea. And so we treat that first. If the patient is pretty happy, then we leave them alone. If they say, what's the next step? Can I do something more permanent, or can I stop using this medicine? Then we go ahead and treat with the Aerolase, or we can treat with a pulse dye laser, or in our case, we use what's called a Max G handpiece on our IPL.
Okay, excellent. Okay, so in the interest of time and the respect of everyone's time tonight, I'm going to take one more question here. So for business building, we obviously have a lot of different treatments that we can do with both the products and the laser itself. Now, when you have a patient come in for, let's say, hyperpigmentation, do you see a lot of these patients branch out to other treatments, or do you have your staff talk to them a certain way in order to get them to go for other treatments? I mean, how does that work in your office?
So in my office, I'm the worst salesperson because I'm not good about sales, but I do love to educate people, and we utilize a variety of things to educate people. So one of those is just before and after pictures. We have them flashing up all the time, and once a patient trusts you, they are going to naturally ask, what else can you do for them? And so our entire approach is just built on giving successful treatments, and when we have the right equipment, in this case, we're talking about Aerolase and PCA. When you have the right combination and you get good results, that patient is naturally going to come to you and ask for other things. So yes, we see it all the time. I was showing you that one patient who had hyperpigmentation and melasma, and then she now unmasked that deep wrinkle that she had in her glabella. So she went ahead and asked to have Botox done. So again, that's branching out to other parts of your practice. And so a lot of our practice is built on word-of-mouth referrals, so we don't do any advertising whatsoever other than having our brand ambassadors be our patients. So if you do a good job, they're going to naturally tell their friends, or somebody's going to say at a social event, hey, your skin looks great, what have you been doing? And after about 2 drinks for most people, they're going to spill the beans that they're coming to see us.
Okay. Now, that's a great way to end the webinar here and the event. So, again, Dr. Chilukuri, thank you so much for your expertise and your time tonight.
Thank you.
And again, have a great night. Thank you so very much.